I had a couple of questions about team communications from last week's scenarios. And there's a few things that I'm going to steal from American Heart Association on team resuscitation that may help with that. The first thing they recommend is that everyone have clear roles and responsibilities. So I know in our simulations and even in real life, there should be somebody designated as the team leader that kind of oversees what they're doing, what the whole team is doing. And then everybody has a specific role in this. So you may have one person assigned to take vital signs, one person assigned to talk to the family, one person assigned to ask a sample history, OPQ or ST, or you may want to do that yourself as the team leader, but you should designate roles and responsibilities for every person. Now, each team member may have a different level of scope of practice, a different level of training, so you have to make sure that everybody that has their roles assigned is capable and okay with doing their roles. You don't want to put somebody in a situation where either they can't do what you're going to ask them to do, or maybe they have not practiced it much and they're just not real comfortable doing it. So make sure you have that assigned and everybody's clear. Now, if you are one of the team members and you do get assigned a role that you're not comfortable doing, you need to make sure that the team leader knows that so we can reassign the roles. Being assigned a role that you're not comfortable doing is something that happens from time to time, and it's okay. You just need to make sure you know your own limitations and then let the team leader know that you're not comfortable performing that role, so then we can assign it to someone who is. We oftentimes look at this in a resuscitation concept, and somebody's applied assigned to be the compressor due to CPR. And I know American Heart recommends that we swap out every 2 minutes, but sometimes we think we can go longer. And if the team leader says, no, it's been 2 minutes, we need to swap out, you need to know your limitations and know that CPR effectiveness oftentimes begins to deteriorate after 2 minutes, and go ahead and let somebody else take over that role. Now, sometimes a mistake is being made or about to be made, and we need to intervene. It could be that somebody, like the team leader, has said to give the wrong dosage of a medication or the wrong medication, or maybe you're the one that's doing the chest compressions, like I mentioned earlier, and you're getting tired and somebody sees that you're not compressing as far as you need to, as deep as you need to. And so we're going to provide some constructive intervention or constructive criticism with this. And when we do this, we need to make sure that we watch the tone of our voice, because a lot of times when we're correcting someone, it's already kind of a sensitive subject. So make sure that your tone is fairly neutral and it doesn't sound derogatory and you use no negative type words. And if you are the one that is being corrected, make sure you realize that it's just they're doing what's best for the patient, and don't take it personally. If you think something was said too harshly, too loudly, too negatively, it's something that can be discussed after the call and not during the call. We should not have any confrontation during the call. But the team leader ultimately is the one that makes the decisions, and we're going to follow those orders. If you think the order is incorrect, you can refuse to do it, just like we do with medical control. If we get a direction from medical control that is counter to our protocols or incorrect, and we can't get a good explanation why, we can refuse to do it. Just realize there's going to be some conversations afterwards about why you didn't follow the order. So make sure that if you're giving the criticism, you say it as nicely as you can, and you keep your voice very neutral, and don't sound too harsh when you say it. Don't shout or speak too loudly, but make sure you are clear on what needs to be done. Now, all members of the team should be made to feel free to be able to say anything about the resuscitation or about the call that may influence what is being done. So anybody should be able to speak up if they think something is being done incorrectly. And everybody should be acknowledged, and that should be considered. And even though the team may not make the decision that is recommended, everybody should be free to speak up. So if you see something that you're concerned about or have questions about, don't be afraid to speak up and say, hey, what's going on here? Let's stop for a moment and reevaluate what we're doing. Now, at some points during the call, during the simulation, during the resuscitation, whatever you're doing, the team leader should stop and ask for a summary of what we've done. And with that summary, we're going to basically summarize what is the current status of the patient, what interventions have been done, how the patient has responded to those interventions, and does anybody have any suggestions on what else should be done. Now, this should be fairly quick. Everybody can have an opportunity to speak, but typically one person kind of does the summarizing, and it may be the team leader. Now, if you have enough members in the team that you have somebody that is recording everything, then oftentimes the recorder is the one that's going to summarize what all has been done. But every once in a while during the simulation, during the call, stop, take a moment, reassess, and summarize how the patient is, what has been done, and how the patient has responded to it, and then from there, what further needs to be done. Now, as far as the communication itself, we want to be respectful, and some things with being respectful, of course, is just the tone of your voice. Trying to use a very neutral, non-aggressive, non-negative voice, not too loud, not shouting. Something else that is very helpful is to try to use names. That also aids in the clearness of the communication. When you name somebody, there's no doubt about who is going to be doing what. So going ahead and using names. It's not necessarily a time to be throwing titles around. They consider names to be a little bit better for clear communications and mutual respect. One of the other things that goes along with this is closed loop communication. So make sure that if you are given an order, you repeat the order back. And we oftentimes do this with medications. So if the team leader says, this patient is having chest pain, their vital signs are adequate, there's no allergies to aspirin, I want you to go ahead and give 4 81 milligram baby aspirins. You would then repeat back saying, I'm going to give 4 81 milligram baby aspirin. And that then closes the loop so everybody is clear on what's going to be done. And it also helps to kind of double check everybody's thought process with giving a medication. But this could go with anything. So if the team leader says, I need you to get a set of vital signs, you can say something like getting vital signs, or I'm going to go ahead and get the blood pressure, pulse, respiratory pulse ox. That might be even a little bit clearer, but that could also lengthen the communication a little bit. So I could go either way with that one. The other thing that is important with closed loop communication is once you're done with the procedure, you go ahead and report that it is done. So in the case of giving the aspirin, after you gave the 81 milligram aspirin, you would then say aspirin administered or aspirin given. And then the team leader knows that that order has been completed, and they should acknowledge you. With vital signs, you would just simply say what the vital signs are after you've done them, and then the team leader should acknowledge that. And that closes all the communication. So closed loop communication is a real important part of team communications. I hope that helped answer your questions on a few things we can do to try to improve team communications. It's not the easiest thing, and it takes practice. And it's one of the things that when I was with my partner and I had very good communications, but we worked together all the time. We would assign roles before we got to the scene, and it was clear who was going to be the team leader and who was going to be the part of the team, and what all the jobs were, what we were going to do. However, a lot of times we responded with multiple different fire departments, so I never had the opportunity prior to arriving on the scene to assign roles and work with those people. So sometimes I come across as being a little bit of a jerk because I might be quick to assign the roles and tell people what to do. So it's something I need to work on. But hopefully we're all clear that when it's a serious simulation or a serious call, that we need to work quickly, and sometimes the niceties get set aside a little bit. Kind of the same thing with talking on the radio. We don't say please and thank you and you're welcome on the radio. It's just kind of assumed. However, in face-to-face communication, sometimes we still want to use some of that stuff. So hope that answered your questions.